before, love working with her. Thank you for joining us today. You may recall Ken at a prior meeting spoke about wanting to hear more about mental health, and since this month is International Overdose Awareness Month, we thought it'd be a great opportunity to talk about substance use as well as some mental health topics. And so Brian has been working behind the scenes, also updating a lot of the data. So we're going to jump to Margaret first because she's a busy lady and she's got other commitments. We really appreciate your time. So Margaret, I'm going to pass it on to you unless Brian, you have any quick introductory remarks.
No, it's been a great pleasure coordinating with Margaret, and she's a wealth of knowledge and action too. And so I'll defer to her to kind of, give her overview. Thank you very much.
Oh, Margaret, you're on mute right now.
Oh, can you hear me now?
Yes.
Yes, we can.
Can you hear me now?
Yes.
Yep.
Margaret, we can hear you, but I don't know.
You can't hear me?
We can.
Oh, you can. Okay, I couldn't hear anyone responding. All right, let me share my screen again. Sorry for this, everybody. Okay. So Brian and I figured we would split up the presentation with me talking mostly about what we know and what's being done around mental health and substance use in youth because of my role with the Norwalk Partnership, which I'll talk about in a minute, but which is our prevention coalition for the city. And we have recent data. So I'm going to share some data, talk a little bit about what we're doing, have one slide on what we're doing around the opioid response right now. And then we're going to pivot over to Brian, who's going to share the data he has on what we're seeing in the emergency rooms. So let me move this thing that's blocking my own screen. Okay, so as Deanna said, I'm Margaret Watt. I'm the prevention director. I work at Positive Directions. We're a small nonprofit on the Westport Norwalk line. We do prevention, treatment, and support for mental health and substance use in adolescents and adults throughout the region. And I oversee all the prevention work, substance use prevention, mental health promotion, suicide prevention, working with a number of towns. And shoot, is this frozen? My screen is frozen. No, here we go. Okay. So the work I'm going to be discussing is conducted by and through the Norwalk Partnership. It's our state designated prevention coalition for Norwalk with the mission of preventing substance misuse in youth and young adults. We recreated the entire coalition in 2020, shortly after I got to Positive Directions. According to the prevention model, it's a coalition model. You can see in the graphic that we're supposed to have 12 sectors or stakeholder groups involved. We have all of them. Our leadership team is an assistant superintendent, police chief, Anna Vivian from Community Services, Triangle Community Center, Courage to Speak Foundation, Human Services Council, school-based health centers, and Positive Directions. So it's really, even from the leadership, it's representing key sectors that all have to come together because it takes a village to take care of youth mental health or substance use. The health department is one of the sectors at the table, and all our work is evidence-based. So it always starts with collecting data, and the work is almost entirely funded through the Centers for Disease Control Drug-Free Communities Grant, which I run for Norwalk. And even though it's focused on substance use prevention, you cannot do substance use prevention in youth or really at any age without addressing mental health. So it's braided from the beginning. We also work very closely with Norwalk Acts on social emotional health work. And so I said we start with data. We have done the only three youth mental health surveys in Norwalk, 2018, end of 2021, and then this past fall around Halloween 22. So I'm going to first start by telling you what we're seeing in our kids. And starting with this past fall, we measured depression, suicidal ideation, and suicide attempt in our students. This was a survey of 7th through 12th graders, a really robust response rate, 69% of kids in all those grades, which was almost 4,000 students who were surveyed. And so what you're looking at here is blue bars are the middle schoolers, the 7th and 8th graders, orange bars are the high schoolers. And these are standard measures of, likely depression. So 1/5 of our middle schoolers, 1/4 of our high schoolers, about 1 in 10 kids who had considered suicide in the past year. And that's scary enough, but a large percent of kids said they had actually attempted suicide in the past year. So this is the picture of mental health in Norwalk right now. We've all been reading about the children's mental health crisis for a while. And the good news in Norwalk is that this has been getting better since COVID. So now let me show you how it's changed from our survey at the end of the 2021 school year, which was a COVID year, to this year. Now the blue bars represent where we were and the orange bars are where we are. So you can see a really big jump or big decrease in depression measures and a decrease in suicide ideation. The attempted suicide looks the same pretty much, but there's like a percentage point difference, a decimal point difference. What we did see though this year, because we disaggregate the data in all kinds of ways, in high school, reported suicide attempt actually increased from 6.0 to 7.2% in the last year. So that is something that, part of what we do with this data is raise awareness everywhere. The schools are taking this very seriously. This has led to a lot of change that I will share. And just to show too that we really do look at the data in all kinds of ways, I wanted to show you which groups are at highest risk. And so this is, again, just the most recent data. And what we're looking at here is that the kids who identify as trans or non-binary have significantly higher levels of depression, almost twice as high as the average across all grades, almost 3 times the level of reported suicide attempt compared to the overall number for the schools. Other groups that are at high risk are the kids who identify as lesbian, gay, bisexual, or self-described. This is now on the depression side right now. Girls, we have 32% of girls still reporting, likely depression. However, it was half of them in 2021. I should say that the depression rate for the LGBTQ population was almost 75% in 2021. So things are going in the right direction. And I would like to think that it's not just because COVID has normalized things to a certain extent, or the pandemic being gone, but also because we have really, as a coalition with all the stakeholders, with the schools, the city, everybody working together, we have really, really sought to address the mental health needs and to support our kids who identify as LGBTQ because of what the data is showing us. I also should mention just under 3/4 of our students identify as straight in the survey, which means the rest are somewhere in the LGBTQ population. About 6% didn't answer. Just in case there are questions here, the students with IEPs, those are students in special education. MLL means multi-language learners, ELL, English language learners. And so you can see there are some differences in the groups reporting depression or suicide attempt, but overall, the numbers are not where we want them to be at all, but things are getting much more close to where they were before COVID. The other piece of the mental health picture that I want to paint for you is what the highest issues are today. And we had really large numbers of students reporting irregular eating behaviors. This is a self-reported survey. It's not a diagnostic tool. We hadn't measured this before. We did so because of clinical folks telling us they were seeing what they thought was an increase in eating disorders. So 1/4 of our middle school students who we surveyed and 1/3 of the high schoolers reporting unusual eating behaviors. Anxiety, this is Anxiety was very high. It was, this is a level of anxiety where the kids said they were anxious most of the time or all of the time. For those who said that, we then said, how much does that impact your daily functioning? And 27% of them said every day or almost every day, they feel unable to function due to the levels of anxiety. So these are the newer issues that have emerged kind of as some of the depression is receding from COVID. I'm going to move on to substance use now. And I want to start by showing you some trend data. As I mentioned, we have conducted 3 surveys, 2018, 2021, and 2022 in Norwalk. And what you can see here is just a drop in the percent of our kids reporting substance use for every one of the major substances that we measure. And I should say that all these measures are, the standard measures used nationally on all this data, so you can compare it to the YRBSS and so forth. I'm guessing that some of you are very surprised to see that our latest data says that only 4% of all of our kids are using alcohol, marijuana, or nicotine. I know that that's been the reaction everywhere. I will tell you that the trend nationally has been for literally decades just a decrease in substance use overall. COVID then really cut into that because kids were at home, had less access to stuff, weren't partying, weren't socializing. It's maybe bouncing back a little bit now, especially maybe with cannabis, but we're really not seeing it yet in Norwalk. So we're at a good moment to prevent these issues. But the other factor that you're seeing here is that this is data for including middle schoolers and high schoolers. So I thought I would show you what happens when you look at it by grade. So this is just the most recent data from this past school year. And you're seeing that it's the 11th and 12th graders who are really using substances to any real extent. But it's still only about 10% of them that are drinking, less than 10% who are, less that are using marijuana or vaping. And these numbers are still not super high. Just another bit of data to show you, if we think of the high school seniors, they're the kids who are the most likely to have, they've had the most years to try and the ones who have ever used substances. So these are literally the highest numbers in our current data. What percent of our seniors this past year said they had ever tried anything? And again, these numbers are lower than in the past. Why this is so important for us all to understand as adults is that I think a lot of times parents and providers can be part of the problem because we all kind of assume based on our own lifetime and what we've seen in the past, we assume that the norm is that there's a fair amount of substance use happening. So when we talk to students, the messages that we send are kind of informed by this view that like, this is, the norm is that there's a lot of substance use, but the norm is actually there's almost no substance use, which means the kids who maybe still are using substances need to really be treated as outliers, and a lot of care has to be wrapped around immediately. Other things that I figured we'd highlight because of the new, cannabis market and all the forms that cannabis can be used in, for the students who said they had used cannabis in the last 12 months, which was only 350 that said they had used and answered this question, how are they using it? And you can see smoking or inhaling and vaping are pretty high. Edibles are also pretty high. We know from the schools and mostly anecdotally, through the parent community and youth community, there are a lot of edibles and dabbing issues. Not a lot, because a lot of kids aren't doing this stuff, but there's absolutely problems happening in our schools, kids going to the emergency room and so forth. And the last piece of data I thought I'd highlight, for those who are using substances, they on average are starting at 13 or 14 in Norwalk, which means all our efforts really need to be upstream. We are working closely with the health teachers to provide them with data and resources. And we constantly are trying to reach parents with education because they're the primary people sending messages to their kids. And speaking of sending messages, my last slide on substances is that a lot of the work around substance prevention that we do in TNP and in any kind of prevention work is seeking to change attitudes because that informs behaviors. And there are several key perceptions that we know make a difference. If kids perceive harm from substance use, they're less likely to use. If they perceive that their parents disapprove, they're less likely to use. If they perceive that their peers disapprove, they're less likely to use. So we measure that. We saw in our study this year that the majority of kids think substance use is risky, nothing close to 100%, but they think marijuana, they're less likely to think marijuana is risky, which is not true at their age. It's associated with a host of issues, including, literal brain damage like IQ loss. Kids are reporting, about 3/4 of kids report that their family is clearly saying, don't use substances. Most kids think their peers disapprove of substance use, which is reflected in the actual consumption rates. But I want you to notice that the kids who think their peers don't disapprove have much, much higher levels of substance use in our data. And that really, I think, makes sense when you think about the fact that really peer groups do things together or influence each other. So the kids who say their peers don't disapprove are 17 times more likely to be using marijuana. They're all maybe using marijuana together. When you tell them that most kids don't use it, they don't believe that. That's not their reality. But when you look at all the other friend groups, that's the reality overall. And then just similarly, I want to show you, because I'm sure most of us are parents or have kids in our family, the students who don't perceive their parents to be disapproving are also much more likely to be using substances. And what we've seen in a community survey that we did a couple years ago is parents are less likely to be talking to their kids about cannabis than anything else. I think there's a lot of discomfort, lack of information. People are they don't know what to do or say. And so you see cannabis as sort of an emerging issue everywhere here, with kids thinking it's less likely to be harmful, people not sending messages to them about it, and then the market normalizing it. So what are we doing and what's being done and what's available in the community? I want to highlight some of the outcomes of this work. That the surveys that we've done just in the last couple of years have really compelled action. So the mental health data in 2021 during COVID, showing the incredibly high rates of depression and suicidal ideation in our kids, have led to new contracts and new funding that the public schools were able to get. They've contracted with local providers. There are a number of new mental health professionals in the high schools and middle schools available, not as school guidance counselors, right? But as clinical people that kids can go to, free, confidential, on-site, accessible, including a counselor specifically from Triangle Community Center to help kids who are struggling with LGBTQ identity issues. All high school and middle school faculty and staff have now received 2 LGBTQ awareness trainings so that they can support kids in their classes, recognize possible issues like bullying, just understand how important this is to people in their classrooms, and how alienating the experience may be for them, and how they're feeling treated and or respected or not. At Positive Directions, we were able to get a grant from the city last year, an ARPA grant, and run 4 single-sex support groups because we saw girls as super high risk. Didn't also want to miss out on the boys. A Smart Recovery Teens group with skill development, a lot of connectedness like behavioral health screenings, social activities. And one of the really exciting things most recently is really, as a city, coming together with funding, ARPA funding through the city. We have a new Teen Nights Out initiative to support our high schoolers specifically, right? It's alternative social activities that are substance free, to get them out and feeling more, independent, making connections. If any of you are working with teens, you know that really their social development is definitely behind, no matter how old they are right now, as a result of COVID. And so this is really an exciting initiative that's where the kids are leading as much as the adults. So this work has led to grant funding to a lot of folks, a lot of different changes. We've had a couple of legislative forums that have led to amendments to the recent cannabis bill in Connecticut. And our partnerships are just continually growing and really, really strong. So a member of our coalition likes to say that Norwalk is a city rich in resources, and it really is. And I think we're coordinating better than we ever have. Just to also show some of the other work that we're doing through the Norwalk Partnership. I'm not going to read through all this, but we work across a 7-strategy continuum. So there's providing information, skills development, support, looking at access, looking at consequences, physical design, policy work. So I wanted to just show there's a whole lot of audiences that we focus on. And we have, again, more and more youth involved in our work directly, not as recipients, but as co-planners and coordinators. And so I did want to highlight briefly the opioids work, because as Deanna said, next week is International Overdose Awareness Day. We get a $5,000 mini grant from the state, usually every year, to address opioids. And what we've done last year and this year is participate in a region-wide digital campaign where you may have already seen some of these ads popping up, depending on what Hearst Media is a huge media umbrella. When you're on any of their websites or related content areas, you may be seeing banners pop up with messages around opioid and trying to send people to the state website, youthinkyouKnowCT.org. We have geofencing in Norwalk. Last year, we had an enormous 4-story digital ad at the mall. We do social media campaigns through the Norwalk Partnership. Right now, in the next week, you're going to see bus ads in English and Spanish on the buses in Norwalk. We put extra money into the regional campaign to have Spanish ads inside all the buses. We've just developed awareness posters for our local pharmacies, because Narcan, which has been available without a prescription at the counter, is now legally going to be available, has been legalized to be available literally over the counter, not at the pharmacy window. So we've made posters and have reached out to all the local pharmacies around putting that information on the shelf. And this poster that you see here is a training that we're doing in 2 weeks down in Sono. So this one is going to be open to the general public. But we want to hit bars and restaurants where people go out and stay out late down there on Washington Street, and an overdose could occur in customers or staff in restrooms, for example. It has been happening elsewhere. So we are providing free Narcan, free training, other overdose materials, and hoping to have a recovery coach there to help people who are open to seeking treatment. Another last slide on this topic I want to show you is really, we are rich in resources in this town. We have navigators and free services to get people connected through the city. This is an incomplete list of the free in-school supports, because more are being added now. We have peer support groups, and we have so many nonprofits, which I highlight over for-profits just because, they tend to accept all forms of insurance. And so we just really have a lot of services. I know I want to give Brian time, and you all may have questions, but I just want to highlight that the challenge with all this work is, I would say, virtually everything you've seen happen that I've presented has happened because of the DFC, the Drug Free Communities Grant from CDC that we have. It's a 5-year grant. We are entering year 5 now. We can get it one more time. I'm assuming we're going to get it unless we screwed something up, which I don't believe we've done. And after you complete 2 cycles, you can't get that money anymore. Prior to this grant at Positive Directions, the city of Norwalk only ever had under $9,000 a year. That's the state local prevention grant that is received by Human Services Council. For a number of years now, that has been targeted to vaping only, so not addressing mental health, alcohol, marijuana. And so we're really looking at, what's the sustainability of this, working very hard behind the scenes, looking hopefully at all the new marijuana, vaping, and opioid settlement funds that are coming down to cities, and saying this work is really important. I mean, the things that I've just listed weren't happening here before in Norwalk, and they've been made possible through funding. So in closing, please check out our website, like and subscribe, and I will stop sharing now. So I couldn't see you while I was talking, but I'm open to any questions if there's time. And I hope this was helpful.
Thank you. Thank you, Margaret. That was really great. Can you hear me okay? Okay, great. Do any board members have any questions?
Yes, Margaret, this is Joan McNeil. Fabulous presentation and great information. I have one question for you. In regards to the mental health slides amongst Norwalk Public School students, what was your population? How large was that population? That's some scary numbers.
We only surveyed 7th through 12th graders. This year in the survey, it was open to everyone. Okay. And they didn't all take it, but 69% across all grades took it. It was 3,969 students who took it. Ooh, so, with surveys, you're usually happy if you have like a 30% response rate.
Right,
so
right.
It was a huge response rate, which really means this data is extremely robust.
Yes. Okay. Thank you. Thank you very much for that.
You're welcome. Sure.
Thank you so
Any
much,
other?
Margaret. Yeah. I was going to say the same thing. Any other questions? All right, Margaret, that was really wonderful. Thank you so much.
You bet. Thanks, Dan. I appreciate being here. And if anyone has any questions that you think of afterwards, I'll put my email in the chat, and feel free to reach out.
Sure.
Thanks so much.
Thank you, Margaret. For the record, just want to let everyone know that Terry Quell is on. She was on before. She's been on since the beginning by now. Good morning, Terry. I'm going to pass it on to Brian now to give an update and to share the data that he's been collecting or analyzing.
All right, thank you, Deanna. So because of time, I am going to move through this much quicker than anticipated. So bear with. I'm going to sound like an auctioneer here, but I'll try to highlight the key points with these slides. And so thank you, everybody. So with this presentation, I'm going to be talking with the focus, for International Overdose Awareness Day, which is August 31st, but obviously with the month having the big focus for this, about Norwalk Substance Use Emergency Department ED visits. And so it's just a quick overview, tying in also to mental health for obviously the Board of Health. And so again, I'm going to be covering this very quickly, but I'll try to hit home the key points. Just keep in mind that this information is up to date as of August 21st. The way this data works, this comes through a system from the State Health Department. It's something called syndromic surveillance. And so it's only identifiable down the zip code. It's not explicit, when it comes to the record level, it's not like the street address or everything else. So there is some, interpretation here, some gray areas as a result of that as well, because sometimes people put in the wrong zip codes or they put in their PO boxes. And so it actually can kind of throw things off a little bit. So again, what it is syndromic surveillance is like a ballpark. So anyways, with that said, I'm going to be using some terminology here that I just want to get you familiar with, and I can obviously clarify as we get further along. I may be saying something like counts or volume, and that's just indicating the number. But keep in mind, the way I did this analysis to offset for, influence from, coloration from multiple visits per day, it's called ED visit days is what I summarized this as. So what does that mean? Say, for example, somebody goes to the emergency department for some sort of substance use related thing. Maybe it's alcohol, maybe it's, opioids, but they come in 3 different times, 3 separate visits. What I've done to reduce that influence, I made it's 1 day that they come in. So 1 ED visit day. But say if they come in 2 consecutive days, that would be 2 ED visit days. But again, if it happens multiple times the same day, because that's kind of throw things off in terms of the estimates. That's why I've kind of summarized it in this manner. But it's just a key point to understand as I kind of speak about this. Along with that, I may also use terminology called unique patients. And again, so the counts are the number of ED visit days. So again, you could have one patient that shows up for maybe 15 days of the year related to some sort of substance use visit. But then when I break it down or boil it down to unique patients, that's only one patient that's come in, because we do get a unique patient identifier that I can kind of section out the data for. Also important to keep in mind, because of the sensitivity of this material, any counts or unique patients less than 7 are not depicted for obviously confidentiality purposes. And along with that, I also share rates. Rates are very important. They're a way to balance the equation, so to speak. So basically, it's taking the numerator, and in this case, I'm using unique patients. The number of unique patients divided by the expected population you would see for that demographic, whether it's race and ethnicity, or for an age group, 20 to 29 years old, or maybe just Hispanic Latino. And so this is based on the ACS, the American Community Survey, U.S. Census estimates for 2021, the 5-year estimates. And that, again, balances the equation. So this is very important from an equity lens, and also really seeing the true weighting of these different demographics to really know who's really being impacted. And then when I also, with race and ethnicity, refer to white or Black African American, that's implying non-Hispanic white and non-Hispanic Black African American. And again, just hitting the point home that with syndromic, it is a ballpark, so we got to take it with a little grain of salt, but more or less it gives us a good idea of what's going on. And so again, this is a little bit about the syndromic, so I'll have to move quickly through this, but again, it's a system that's developed by the state, really to help us with the syndromes and conditions that are reportable. And it's a very great system to kind of look at different conditions and things like that, especially for substance use. And so it's rolled out, around 2018, 2019. Like I mentioned, it's only specific down the zip code. There's some caveats. It doesn't have full medical notes. It's only input notes from, intake and discharge. So it doesn't have medical records in terms of like, the assurance billing codes, physician notes, test records. It does not have that information. It has to be information that's captured there, and they put the coding in for the intake and discharge for that individual. And so just to get you familiar with it, there's a syndromic classifier definitions, and basically this is what's used to assess for this. It's looking at terminology and certain medical codes. So as an example, for anything that's alcohol associated, there's certain ICD codes that'll be F10.0 to F10.1, if that's marked into the record, as well as any sort of indicator. So as you can see, alcohol, any sort of potential misspellings, drinking, ETOH, which stands for ethanol, excessive drinking, binge drinking, and then also some negative terminology that may not actually imply alcohol that offsets. And so it looks at these plus indicators, minus indicators to then add it or minus it from the actual tally, and incorporating it in relative to that umbrella classifier definition, say, for example, for alcohol. So I just wanted to kind of make sure we understood that. Again, I have to move through this really quickly, otherwise I'll spend more time on this. And then the other thing is I color code this, so you'll see with this data, any sort of high unique patient count or the highest unique patient count is in a yellow box. Red box is implying a high unique patient rate. So again, counts versus rate. And then if they're both in agreement, they're both the highest. In general, it's pink. And any visuals that you're seeing are for patient rates. So again, it's a better way to kind of look at this and compare. And the other thing actually that's important right hand side here is the zip code map. So we have 06850, 51, 54, 55, 53. So the important take-home points here, 06854 is the Sono area, 06855 is like the East Norwalk area, 06853 is the Rowayton area. And you'll see a little bit more about that. So without further ado, let's jump right into this because I want to be mindful of time. So the overall substance use situation by ED visit days, you can see here, this is looking at alcohol, just suspected drug overdoses, suspected heroin overdoses, opioid overdoses, suspected marijuana, THC influence, and then stimulant overdoses as well. And generally what you're seeing here with these, for the 2019 forward till now, generally speaking, almost just like just a day or so ago, the data is representing here. The black or gray line is alcohol. You can see it's the largest by volume or count over the years, and you can see how it's been gradually increasing from this 963 to 1143 here for 2022, and obviously 2023 is to be continued so far. And with that, the same story is also applied to drug, opioid, and marijuana THC. Since 2019, it's been on the gradual incline. Heroin and stimulants had a little drop down in 2020, likely probably because of the pandemic, and keep in mind there's some of the lower volume ones. but it's been on the increase since 2020. So that's important just to keep in mind. But again, alcohol is kind of our number one, whether it's the reason for the ED visit or it's a a part contributor, and maybe just something else. Somebody fell, but they were also under the influence, things of that nature. So again, keep in mind those gray areas with syndromic. So with that said, these slides are going to be very information dense. So I'll just summarize it really quick for you. Just using this as an example, this is suspected drug overdoses. So this is kind of like the umbrella for, say, the opioids and for heroin and, even the marijuana and all that. So it's kind of consolidating everything. And so to summarize some of the information here, there's about 216 unique patients from the time period of the most recent year. So that's August 21st, 2022 to August 20th, 2023. So just the other day. And then that resulted in 200, there's 216 unique patients, 249 suspected ED visit days, but then an additional, so again, this is something I was mentioning, 33 ED visit days. So outside of that, these individuals have returned for 33 additional ED visit days, again, not ED visits, which equates to about 13% excess. The presumption is if somebody is coming in for a drug overdose, it's hopefully just that one time. So this is then just looking at that 13% that's extra over that. So with that said, breaking it down demographically, majority is male. As you can see here, the rates, and these are in green, so that means they're valid rates. If they're in the red, it's too low. Again, it's lower than that 20. And so it's not considered reliable. So we can't utilize that, but the green ones we can. And so then comparing the rates, the majority is male. It's a 1.2 times greater rate compared to females. 30 to 39-year-old age group is the largest or the highest rate here, along with 60 to 69. The 06854, which is a common theme here, is the highest rate. And so again, it's the Sono zip code. And then also for race and ethnicity, as you can see here, the highest rate is Black African American, which is about 2.5 times higher than whites. But what's interesting here, and again, you got to keep in mind the terminology. If you look at unique patient count, there's 97, non-Hispanic white ED visit days, or patients actually, but only 56 Black African American. But again, when you calculate rates, which balance the equation because the Black African American population is smaller in comparison to the white population in Norwalk, when you look at that, it's actually a bigger concern. And so again, keep in mind the difference between volume and rates. And so with that said, now we jump into opioids, because this is obviously another important one to kind of keep an eye on. About 19% excess ED visit days with 79 unique patients. Summarizing real quick, 1.3 times greater rate for males versus females. 30 to 39-year-old age group is the highest rate, and then 2.7 times greater rate for Black African American versus whites. And again, you can kind of see 06854 kind of being the area or zip code with the highest proportion there. Heroin, as you can see here, a lot of the rates except for males is in the red, so that means it's less than 20, so it's not considered reliable. We need more, unfortunately, numbers there to kind of indicate that. But in the other lens, it's a good thing that it's actually low enough volume that it's indicating that. So the only rate that is considered reliable or stable is that males are the larger rate or proportion of that. And it's very apparent here when you look at the blue versus the pink, blue indicating male, pink female. And so just to summarize really quick, male's the highest rate, 30 to 39 and 50 to 59-year-old is largest volume. And then white's the highest volume for heroin. But again, that's only equating to about 33 unique patients for the time period of the most recent year. Stimulants, same story, and actually it's even lower. So 24 unique patients, no excess ED visit days. But all these rates are too low to actually be reliable. So again, it's a volume thing. And so male's highest volume, 20 to 39-year-old age group is the highest volume as well. And then white's highest volume, Hispanic whites. All right, so these are the more interesting ones. The next two, this is alcohol and marijuana, which are, obviously more recreational substances that are legally available. And so alcohol is the biggest volume, as we established before. So we have 705 unique patients, 440 excess ED visit days, or about 38%. So that means repeats, again, for ED visit days. Males are about 2.6 times greater rate than females. And then the 30 to 49-year-old age groups are the highest rates. But as you can see, it's a pretty solid curve here. Looking at from the 20 to, if not 69-year-old age groups as being a good proportion of that. So there's a wide band when it comes to alcohol. And again, keep in mind that 06854 is the common area for that. What's unique here is there's 2.1 times greater rate for Hispanic Latino versus whites. Black African American is also high as well as 10.01, but it's 11.69 for Hispanic Latino. So alcohol is interestingly Hispanic Latino larger proportion in terms of ED visits when you look at it from a rate perspective. And then again, I know time is tight. So with that said, marijuana, you can see here, 185 unique patients, about 7% excess ED visit days, 1.7 times greater rate for males. 10 to 29-year-old is the highest age rate, rates for age groups. And you can see here how that curve looks and skews much lower in terms of younger age. And you can even see, and this is just looking at the rate, but less than 10 is actually even in play here too. 06854, zip code that's most impacted by this for ED visits. And then also for race and ethnicity, 4.1 times greater rate for Black African American versus whites. But Hispanic Latino is also still very high as well. And then looking at mental health. So again, switching gears, and I don't mean to move so quickly here, but I've got to cover a lot. As you can see here on the bottom, this blue column here is suspected mental health ED visits, and you can see that's been on the growth as well over the years. And if you look at this for 2022 and 23, the green and purple by month over the last 5 years, and you can see how since for February to July so far, they've been 2022 and 2023 have been consistently the highest in comparison to the other years. So I think that's an important point to take home here. So it's on the rise, a continuous rise. And so that's 2,100 unique patients for the most recent year, 31% excess ED visit days. So mental health tends to yield multiple ED visits for these individuals, and that's ED visit days too. So you can imagine how it would be this number if it was just looking at it for ED visits. But then it's a 1.5 times greater rate for females versus males. So this is more a larger proportion issue for females. And what's interesting here too is a 1.5 times greater rate for 80 years plus versus 30, 39 years old. So you can see here with this curve and looking at it by rate when it's proportioned out, 80 plus years old is actually the highest rate here. And looking at that data a little bit further, that's definitely linked to dementia, any other kind of mental deterioration. Just looking at that further, so that's partly what's playing into this, along with anxiety and the inability to live alone. That's kind of complicating a lot of these things too. So that's partly what it is, and the reason for that with 80 plus. But then if you look at for the next highest, like by volume, it's 30 to 39-year-old age group. And it's interesting here. It's almost tied, but actually 06855. So East Norwalk's a little bit higher by rate. But 06854 still usual suspect there. And then for race and ethnicity, Black African Americans actually the highest rate at 1.5 times greater versus whites. And so again, largest volume is whites, non-Hispanic whites, but non-Hispanic Black African Americans is the highest rate for that. And so just really quick, years of potential life loss. This is from Data Haven. And so with their assessment comparing kind of the Fairfield County area, years of potential life loss. So basically, this is using the assumption that 75 years of age is when most Americans would live to. Anytime somebody dies prematurely from that, you subtract from that, and those excess years are then tallied up to kind of see, all the premature years of death that an individual experiences, and you summarize that relative to those years. And as you can see here, for comparing the different kind of conditions that contribute to that, you could see how almost close behind COVID-19 for Norwalk, poisonings, including overdoses, is not far behind. So 916 versus 818. Obviously, some of the leading ones are heart disease and cancer, but it's just interesting to see that in scope. But you can see how Stratford and say, Bridgeport have much higher concerns there, and even Danbury, but still it's high. And something just to emphasize there, along with obviously over the years, the overdose deaths and how they increased over the pandemic. And then the other big thing that you've been seeing in the news too is obviously fentanyl is a major contributor, and it's been growing over the years. As you can see here on the right-hand side, on the left-hand side, xylazine, which is like an animal tranquilizer or horse tranquilizer, has also been growing as a player in, complicating and almost creating a synergistic effect that increases the lethality of, anybody that's, injecting heroin or, taking other substances as well. So it's a growing player nationally. There's actually been the alarm raised from the DEA, but Connecticut's not an exception here. And so this is just looking at how over the years, how it's been a contributor in a growing number of overdose deaths. So that's something else to keep in mind along with fentanyl, xylazine. So in summary, substance use keeps growing. Mental health is growing as well in terms of concerns for ED visits. Females generally are more likely candidates to seek ED visits for mental health. whereas substance use is more of a male dominated issue or concern for ED visits. And then, when you kind of break it down by like what I mentioned before, just really succinctly, the typical criteria, say for ED visits, and the most disproportionately impacted is non-Hispanic, Black, African Americans, and especially apparent for marijuana, THC, Hispanic, Latino for alcohol. 30 to 39-year-old age group remains the highest and common theme for opioids, and obviously the noticeable curve with alcohol being very wide too, 20 to 69 years old. Marijuana, THC, alcohol also contributes to youth, also having some ED visits, so less than 18 years of age. 06854 is, the most impacted compared to conversely, Rowayton actually having the lowest, generally speaking. Only alcohol is the only one that pushes it into kind of a little bit more focus there. So that is my overview. Really sorry about that because I know this is a substantial amount of time. If you have any questions, let me know. Thank you.
Thank you, Brian. A lot of material to cover and did it quickly. Yeah. Thank you. Does anybody have any questions for Brian? No. Thanks, Joan. We can also send follow-up information too afterwards because I know it's a lot of material.
That would be great. Yeah.
Hey, thank you so much, Brian. So I wanted to cover a couple things related to our department, related to mental health, but then also talk about a new opportunity through NACCHO as well, potential opportunity. So I'm going to share my screen. Give me a second. Can you all see the slides okay?
Yes.
Okay. So you may recall in our strategic plan that the first goal is about continuing to build and support a diverse, happy, and skilled workforce. And this is something that came up a lot during our strategic planning sessions where we talked about the mental health, both of the community and of the workforce, and in particular, the public health workforce, and a lot of national reports that had come out comparing the mental health of the public health workforce during the pandemic in comparison to the general population, and how in like every indicator, the public health workforce was doing actually worse than others. We also talked about some of the local data that we collected here to get a pulse on how our staff was doing. And so one of the parts to this related to addressing the mental health of our workforce was to build a supportive work environment. And so we've started efforts to develop a supportive work environment policy. And so this will include provisions that contain employee wellness, work-life balance, employee recognition, and an inclusive culture. And so we've been thinking about, how do we go about doing this? So we've been looking at different resources and reports. And one of the things that we've been looking at is the Surgeon General's framework for workplace mental health and well-being. This framework and report were released in 2022, and it provides organizations and businesses with ways to improve their workplaces to support mental health and well-being. Reading through this, I thought, this would be a really good guide to us as we develop our supportive work environment policy. It really helps identify the essential components that should be included within a policy to support us here. And so this framework includes 5 different essentials. It includes protection from harm, which really involves prioritizing workplace physical and psychological safety, making sure employees have adequate rest. It's about normalizing and supporting mental health. It's about operationalizing DEIA norms, policies, and programs. So safety and security, essentially. And then the next part is, another part is the work-life harmony, which is, how do we provide more autonomy over how work is done? How do we make schedules as flexible and predictable as possible for employees? How do we increase access to paid leave? How do we respect boundaries between work and non-work time? Mattering at work is important. It talks about providing living wages, engaging workers in workplace decisions, building a culture of gratitude and recognition, and connecting individual work with the organizational mission. And the other essential is connection and community. This is where we talk about inclusion and belonging, How do we cultivate relationships that are trusted within the workplace? How do we foster collaboration and teamwork? And then the last part is opportunity and growth. So how do we offer quality training, education, and mentoring? Are we fostering clear, equitable pathways for career advancement? Are we ensuring relevant and reciprocal feedback? So a lot of these essentials sound sort of similar to a culture of quality improvement. So there's a lot of things that are related here. And I thought this would be a really good framework for us to build off of our efforts. And so I reached out to staff because I wanted to invite everybody to participate in the policy development. You may remember in the strategic plan, we identified certain key positions to be involved, but I really wanted to give everyone the opportunity to be involved. So this right now is our planning team. So we're organizing 5 meetings around the different components of that framework that are going to occur in September and October. And what we're going to do prior to each meeting, we're going to summarize the evidence-based strategies and best practice examples for each of those different essentials within the framework. We're going to be looking at the resources. The framework itself, the report has different resources and technical assistance, but there's also other organizations that we can pull from, like the Health Action Alliance, that has a lot of great information and resources for us. And I want to kind of structure it similar to how we kind of do some of our other planning efforts. You know, we're going to be having discussions with the planning team where we identify ways we're already implementing practices in support of the 5 different essentials of the framework. We're going to discuss areas of weaknesses and threats to ensuring the different essentials. And then we're going to discuss ideas that staff have for improving these different areas. And then we know that everyone is busy. And so some people might potentially be interested in participating, but they can't commit to, being at those meetings. So we're going to be developing a survey afterwards that, staff can provide feedback. And then we're also going to find ways that people can submit things anonymously as well, if they don't feel comfortable in, having their name attached to it. So that's sort of our approach to thinking how we're going to be developing that supportive work environment policy. So I wanted to just ask the board, take a pause to see, what do you think about this approach for developing the policy? Are we missing anything that we think should be included? And do you have any ideas for us?
It's Terry Quell. I think the strategic plan looks really good. I've not seen that model before. I'm not sure strategic plan was the right word, but the Surgeon General's model was really good. I've not seen it, and I think it's really strong. And I think the plan that you have sounds very good to me. And I like the fact that people can do things anonymously, because I know sometimes, as you said, people are not always comfortable sharing with their name attached.
Great, thank you, Terry.
I'd like to echo that also, and I think the involvement of staff is critical. That's the day-to-day that's happening with the consumer in mind also. So I think that inclusion is critical to the success of the program.
Thank you, Ken. Okay, I am going to pull up my slides again. Okay, so this all ties to the workforce development funding. You may recall that the CDC announced funding to go to state health departments back in December, I want to say. And the state health department wrote in their application that 40% of this workforce development funding would go towards the local health departments in Connecticut. And so we have $300,384.98 to spend. That's the calculation. We are currently working on putting together a work plan for this funding, but it was set up as a 5-year grant program, but it's taken some time to just establish and figure out how to get the money to the local health departments. And so we're going to have about 4 years to spend the money. The funding ends November 30th, 2027. And that money is flexible. It can be spent, you can spend it in a year if you want, but you have 4 years to spend it, and you have to spend it by 4 years. And these are the things that we're allowed to spend the funding on. We can use it to recruit and hire new public health staff. We can retain public health staff. We can support and sustain the public health workforce, train new and existing public health staff, and strengthen workforce planning systems, processes, and policies. To me, when I thought about, how do we best spend this money, I thought, well, our first priority should really be about helping staff recover from the pandemic and thrive in the future. And that's, linked to what we have in our strategic plan, right, to support our workforce. So I thought it was really important to support our current workforce. And then really it's just another priority would be to support our department's needs. We want to have a skilled workforce that can meet the needs of today's, Norwalk Health Department and the future Norwalk Health Department. And then also think about staff themselves, like what are they interested in? How do we support their development and growth in the field of public health? I sort of felt like there's not enough funding to pay for full-time staff with benefits. Like that would be gone pretty quickly if we spent it on, looking for new staff. So that's sort of where our thoughts were with some of the priorities. We have to submit the work plan at the end of this month, and then we submit the budget once DPH approves the work plan. And so they gave us a potential list of specific activities underneath all those 5 different main areas. And so we've gone through the list. We've done a little bit of a crosswalk of the options to identify areas that are linked to our different department plans. Is there a linkage to our strategic plan, our workforce development plan, our QI work? And we've also identified areas that, are of interest to staff. Most of what we identified falls within those 3 middle areas: retain our staff, support and sustain the workforce, and train new and existing staff. And I guess our other thought was that as we develop the supportive work environment policy and we get staff engagement, we'll get good ideas from them. So that could potentially also guide the use of these funds in the future. So I'm going to stop sharing again and just see, what do you guys think? I know that was really quick, but that's sort of our approach to the workforce development funding. Do you have any thoughts, any ideas for us?
I think some of the grants that are out there, it's difficult when you look at sustainability issues. I mean, it's got to get spent within a certain amount of time, and then all of a sudden that resource goes away. I mean, that's why it's tough to do it with people with positions. So it may be beneficial to have it really geared around programs where time it can be spent maybe on consultants and some other. Not that I love consultants, but it is an easier way to fund those components that you're looking for, even to function as as semi-staff. But then it's known as a longer term play. You can do that with programs than you can with positions. So I agree with you on that one.
Thanks, Ken. All right, the last thing I wanted to talk about within this part of the meeting is Behavioral Health 360 initiatives, which is a new thing for NACCHO members. NACCHO is the National Association of County and City Health Officials. They are partnering with an organization called Credible Mind to figure out ways to strengthen everyone's mental health in the community. And so they recognize that there's a lot of mental health needs out there. A lot of it could require treatment and counseling, very intense, like one-on-one treatment. But there's a lot of mental health needs out there that could have more of that prevention framework, providing people with resources where they can, look for evidence-based ways to improve their own mental health. There's, some people might want to be doing things, on their own, and so what they've done is there's this resource, and I'm going to share my screen again. Hold on. They're looking for ways to provide access to this digital mental health platform. So they're providing grants and sort of startup funding for a lot of different health departments across the country to have a solution that could be co-branded within your local community, and you can link to local resources, like all of the things that Margaret was talking about. But you can also make it available to everyone. And so what it is, it's an annual license. If there's some startup fees, you can offer it in different languages, like we could offer it in Spanish. And it would provide people with the opportunity to research. Can you see the Credible Mind example on my screen?
Yes.
Yes.
So this is the platform. And this is an example from another county. So you can look up all different topics like anxiety, stress, burnout, depression. If you click on anxiety, you can take different assessments. You could link to, there's different articles that can give you advice, like in terms of from a parenting perspective. It links to videos, to books, to FAQs, to different podcasts, different apps, and you can like filter it for like paid apps or free apps. But it can give you different, like these are things that can help you with anxiety that have been found to help you. So it's a way to like offer a platform for your entire population. And it also offers ways to kind of track overall, like you're not going to get specific individual data for people, but you can kind of get a pulse of the community and how the community is doing with their mental health. And so this is something we've just been exploring. We went to a webinar on it. I heard about it at a national conference at NACHO last year. And we've been thinking about, applying for funding for this, for grant opportunities to just add another resource, to our toolbox for the community. And as a member of the National Association of County and City Health Officials, this is one of those benefits that we could potentially get. So just wanted to let you know that we're looking into this and trying to see if we'd be able to bring something like this to Norwalk. So I know I went really quickly and I know we're over time for our meeting, but I can send everyone the link afterwards for you to explore. But if anyone has any initial thoughts, let me know. But
I think it looks really good. And, when people have issues like that, they don't know what to do. And they go to the internet and they get random sites that, know what the background is. So if we had something like this, they could go to a trusted place, the health department website, and know that what they're going to is something that would be worthwhile and kind of safe to be used.
thanks, Terry.
Deanna, does the website also give emergency phone numbers, etc.? So if someone is looking at one of those videos, they'll be able to contact someone?
Yes, we can do that. Yes.
Yes. Yeah. Okay.
Thank you, Joan. That's a great question.
Yeah, I think that trusted source type of idea for many of these areas, the health department can become that. That is definitely a sustainability model.
Yeah.
Where you are the voice of reason, the voice of accuracy, the information that Brian puts together, a way of encapsulating some of that to be able to educate the community and help move that ball down the road slowly, but that's kind of how we do it here. I think that'd be a great use of funds, is to help promote the accuracy and volume of, and not just copious volume of stuff that we went through this morning. Nobody's going to be able to read it that fast. But I think that the content and the algorithms and the result of those events can be published in a way that educates the consumer. And I think that'd be a very important role for what we do.
Yeah.
Thank you, Ken. Right. Do you guys have 5 more minutes to hang on for me to show you some quick to wrap up the rest of the meeting? Is that okay?
Yeah, that is okay.
Okay.
Yes, fine.
All right. So actually, can we do approval of the minutes right now, and then I'll wrap up the rest of the meeting? I have a motion for approval of the July 25, 2023 meeting minutes.
So moved.
All right, I think so. Terry, I'm going to put you first and Ken a second. Any discussion? All right, all those in favor say aye.
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 Right, thank you. Minutes pass. All right, quick director's report. So as you all know, I like working on organizational charts. And so we've been updating and restructuring the health department for several years now, as we're trying to reflect like where we are today and what's needed for a 21st century local health department. We've been utilizing the national standards and accreditation as a lot of the basis for this, but we've also been looking at, what are the needs of the community in Norwalk? What's our strategic plan, our strategic direction? What are we hearing from, both the local Norwalk community and the state as well, as far as like what is needed for the health department. We've added the Epi and Informatics division. We transformed health education to community health. We've incorporated the lab into the clinical, the preventable diseases work, as well as the environmental health work. And we've also had to rely on the state lab for a lot of our lab work now. We've really built our volunteer base, and so we've placed our emergency response team within our org chart. We've updated many different positions. As part of that, we added more cross-cutting and general staff, to support quality improvement, performance management, and any cross-cutting public health issue. As we know, we talked about sustainability of funding, and so often public health funding comes by topic and by disease and by need, but as we know, there are always public health needs. And so I think it's really important to have some more of those generalist staff that can pivot and go to whatever we need to address at the time. And so I'm going to share my screen. Or chart. So we have placed, can you guys see that okay? Is it zoomed in enough? We have placed the project coordinator and the public health program associate. But we had sort of said, can you guys hear me okay still?
Yes.
Yeah.
Yeah.
Okay, sorry, I'm getting a message that Zoom quit on me. Okay. We additional positions within the administration division, but the health operations manager has been what's listed as a supervisor administration division, and the project coordinator has also been in there, but we haven't really been operating that way. And so I know that the Connecticut Department of Public Health has an office of a commissioner that has many different functions and staff to support the entire department. And so that's when I got an idea like, what if we did something like that here? And I looked at a lot of different org charts where similar roles were placed within, where they're placed within the organization. And so I thought, what about this office of the director? I kind of feel like it fits well with how we're operating. And so I put this together as a draft to place them, trying to update some of the other division titles as well, like to keep informatics in there, and then preventable diseases and clinical services, because a lot of what falls under Darlene's division is clinical. And then a lot of times we need different org charts for different needs. So sometimes it's just, what are the divisions? What are the functions of the department? How do we show that? What's the leadership? And so I've come up with all these different versions. And I know I need to update the logo because we now have the new city logo, so I will work on that. But this is sort of where I'm thinking, this can show some of the cross-cutting areas, the more specific areas. How do we describe the different functions within the division so it makes it clear like what's going on in each division? Here's the staffing themselves, this is where everyone falls, the different positions and roles. Here's like the leadership. And the leadership team. So this is sort of what I've been coming up with.
Deanna,
it didn't
only
show the
showing
other
the
slide.
first thing. We're not seeing the bottom that you're talking about with the leadership team.
It's not showing those different slides. It's just showing the one with the colors.
Sorry. Let me.
It's okay. We saw it.
Which I like the colors because
Yeah,
of
I
the funding sources, but the other ones are nice.
Absolutely. I think it's important to show those funding sources. And I did have one thought where it says the Board of Health volunteers, it's attached to the mayor. I'm wondering if it should have maybe a dotted line to the director of health as well. Because we work so closely with you. When I saw it attached to the
Yeah.
mayor, I thought, well, it almost looks like we report to the mayor, which we do, he appoints us. But I do think that maybe there's another line that needs to be there somewhere.
That's great. Yeah, I could definitely incorporate that. Thank you for that suggestion, Terry. Any other thoughts for the org chart?
Did you want to try to pull them up again if they could see them? I don't know.
I did send them before the
Oh, you sent
meeting.
them?
I saw
Oh,
that.
okay.
Yeah.
Mhm.
Yeah, it actually printed nicely on one page.
Yes. Good. And once we finalize these, then we can post them on the website for everyone to see too. But if you have any other thoughts before we finalize them, please let me know. I'll add that dotted line and I can send that to everybody so you can see it.
Okay.
Thank you, everyone. Brian, do you want to give a very, very quick update on where we are with COVID right now, just to let everybody know?
Yeah, sure. Thank you. COVID's still on the rise. It's a very gradual increase. You've probably seen in the news about the some variants that are coming up, especially the newer one that has about 36 mutations, so a substantial jump. So that one's, currently under surveillance very closely just to see where it kind of manifests in terms of, being kind of like another Omicron-like event. But just something you might see in the news. Just keep in mind, though, that it's anticipated that, the COVID activity will continue to rise to some degree because school year is starting in just less than a week. The other two things in terms of vector-borne disease, really quickly, the first West Nile virus positive human case in Connecticut was detected. And so just, something else to just be mindful about managing, mosquitoes. Norwalk did have West Nile virus positive mosquitoes, a pool of it. So that's, and we also have proximity with New Canaan, Stamford, and Darien that did also have West Nile virus positive mosquitoes as well. So it's a very real concern, something, everybody should just keep in mind. Then with tick-borne disease, you probably also seen the news too, with the Powassan virus.
Yeah.
Think of it as almost a West Nile virus for ticks. It's kind of similar in that sense because it causes neurological symptoms. It has a potentially 10% case fatality rate, but it's very limited right now. It's only been detected in counties outside of Fairfield County with the human cases that have come up. Nothing fatal this year, but it did have some fatalities last year, a couple. And so just keep in mind, ticks and mosquitoes kind of still following similar kind of guidance measures in terms of prevention. So again, just avoid areas where you might, encounter them. Use insect repellent. It applies in both situations, and an EPA, registered one. Apply it liberally to protect yourself. Check your pets for ticks, and then wearing appropriate clothing, especially dusk to dawn for mosquitoes, but then also even going to the woods for ticks, making sure you wear long pants, long sleeves, things like that, and just check yourself, especially afterwards. Very important. But yeah, prevention is the name of the game in all these situations: COVID, West Nile virus, and mosquitoes, and then also, Powassan virus and any other tick-borne disease. Thanks.
Thank you.
Thank you, Brian. Any questions for Brian? All right, the last item on the agenda is public participation, but we don't have anybody on the meeting from the public, so no public participation. All right, it is 9:21. I'm sorry, guys. There's a lot of information, but I thought it was a really great information. So thank you for your time. We really appreciate it. And thanks, Brian. Sorry we made you go so fast. But if there's any additional information you want to spend more time on next month or any future months, please let me know and we can definitely come back to it.
Really great
else?
presentations today.
Yeah.
Thank you.
A lot of
Thank you.
information.
Yes, they were. Yeah, thank you.
Right. Thank you all. Really appreciate it. We will adjourn at 9:21. Have a